I think we will make a start, and Paranita or Caribou, if you can put some info in the chat if necessary about interpretation, etc., because we've got a very tight schedule. So I think we better make a start. Greetings, everyone. I'm Tim Sladden, HIV advisor with UNFPA, and it's my pleasure to welcome you all to this 9th webinar of the community of practice for working with for key populations. We're going to look at how we can address stigma and the resulting discrimination, which is undoubtedly, I think, one of the key issues driving and sustaining, perpetuating the epidemic of HIV, and particularly in key populations. So it's a critical issue, looking at stigma and resulting discrimination. Today, we're going to look at some of the evidence that has been amassed over the course of the pandemic and the guidance that's been developed for addressing stigma and discrimination. And then we're going to have a bit of a deep dive into some of the country examples of how programs have incorporated ending stigma and discrimination and addressing it and trying to tackle stigma and discrimination. So again, please select the language of your choice from the globe icon at the bottom. And we're going to start off, first of all, with Anne Stangl of CDC is going to give us an overview of the evidence about stigma and discrimination and how we address it. So I'll hand over to Anna now. Anne.
Okay, thanks so much. Thanks so much, Tim. So good morning, good afternoon, and good evening, everyone. I'm so pleased to be here with you today to share an overview of evidence-based interventions to address stigma against key populations. Next. So I'd like to begin today by discussing why it's so important to address key population stigma and discrimination. First and foremost, the experience of stigma is an infringement on our human right to live a life free from discrimination as enshrined in the Universal Declaration of Human Rights. Next. Secondly, evidence is mounting across the HIV prevention and treatment cascades, demonstrating how stigma, discrimination, and violence are impeding the achievement of 95-95-95 targets among key populations. This slide highlights a few of these studies. For example, under combination prevention, experienced stigma has been associated with lower rates of condom use for transgender people in the Dominican Republic. Under the first 95, a study found that stigma among men who have sex with men and female sex workers in Kenya led to higher odds of reporting delay or avoidance of counseling and testing. And from a policy perspective, we can see that laws can either encourage or impede knowledge of HIV status. For example, Kavanaugh et al. Found that globally, gender-based violence laws were associated with higher knowledge of HIV status. Conversely, sex work, drug use, and same-sex criminalization are all associated with lower knowledge of HIV status. Under the second 95, a systematic review of studies with female sex workers in sub-Saharan Africa revealed a strong association between stigma and discrimination and poor linkage to care, ART initiation, and retention in care. And globally, lower access to HIV treatment for MSM is associated with criminalization of same-sex behavior. Under the third 95, higher internalized stigma scores have been significantly associated with missing an antiretroviral treatment dose among female sex workers in the Dominican Republic and with poorer viral suppression among people living with HIV in Zambia and South Africa. And among trans women in Brazil, lifetime experiences of sexual violence were found to be associated with subsequent reduced likelihood of retention in HIV care and viral suppression. Next slide. According to UNAIDS Global AIDS Strategy, to reach the 95-95-95 targets, it's critical for countries to achieve the 10-10-10 societal enabler targets. Specifically, countries are striving to achieve less than 10% of people living with HIV and key populations experiencing stigma and discrimination, less than 10% of people living with HIV, women and girls, and key populations experiencing gender inequalities and gender-based violence, and less than 10% of countries having punitive laws and policies. Next slide. Now that we're clear on why it's critical to eliminate key population stigma and discrimination and what the societal enabler targets are, I want to share with you a tool called the Health Stigma and Discrimination Framework. The framework, together with existing data on HIV and key population stigma and discrimination in your country context, can be used to guide discussions with key stakeholders to determine where you need to focus your efforts. I'll spend a few minutes on this slide to walk you through the stigmatization process, introduce some key terminology, and discuss how you can use the framework. The Health Stigma and Discrimination Framework articulates the stigmatization process as it unfolds across the socio-ecological spectrum in the context of health. The process can be broken down into a series of constituent domains, including drivers and facilitators, stigma marking, and stigma manifestations, which influence a range of outcomes among affected populations, as well as organizations and institutions that ultimately impact health and society. The first domain refers to factors that drive or facilitate health-related stigma. Drivers vary by health condition, but are conceptualized as inherently negative. They may range from fear of infection through casual contact for communicable diseases to concerns about productivity due to poor health for chronic conditions to social judgment and blame. Facilitators, however, may be positive or negative influences. For example, the presence or absence of protective supplies in health facilities can minimize or exacerbate stigmatizing avoidance behaviors towards populations with infectious diseases by healthcare workers. Drivers and facilitators determine whether stigma marking occurs, in which a stigma is applied to people or groups related to either a specific health condition or other perceived difference, such as race, class, gender, sexual orientation, or occupation. Intersecting or intersectional stigma occurs when people are marked with multiple stigmas. Once a stigma is applied, it manifests in a range of stigma experiences and practices. Stigma experiences can include experience discrimination, which refers to stigmatizing actions or omissions that are prohibited under international human rights law, for example, losing housing because of one's HIV status. And experience stigma refers to stigmatizing actions that fall outside the purview of international human rights laws, such as double gloving or gossip. Another stigma experience is internalized or self-stigma, which is defined as a stigmatized group member's own adoption of negative societal beliefs and feelings, as well as the social devaluation associated with their stigmatized status. Perceived stigma, which refers to perceived stigma, which refers to perceptions about how stigmatized groups are treated in a given context, and anticipated stigma, which refers to expectations of bias being perpetrated by others if their health condition becomes known, are also classified as stigma experiences in the framework. And lastly, secondary stigma, which refers to the experience of stigma by family members or friends of members of stigmatized groups, is included under stigma experiences. Stigma practices can include stereotypes, prejudice, stigmatizing behavior, and discriminatory attitudes. The framework considers stereotypes and prejudice as both drivers and manifestations, as they both fuel and are reinforced by the stigmatization process. Stigma manifestations go on to influence several outcomes for affected populations, including access to justice, access to and acceptability of healthcare services, uptake of testing, adherence to treatment, resilience or the power to challenge stigma, and advocacy. They also influence outcomes for organizations and institutions, including laws and policies, the availability and quality of health services, law enforcement practices, and social protection. So now let's get back to how you can use the Health Stigma and Discrimination Framework to plan programming to reduce and mitigate key population stigma and discrimination. In terms of where to intervene, ideally we want to stop stigma marking from occurring. So interventions often focus on the drivers and facilitators of stigma. While we'd like to prevent stigma from being applied, we also need to be prepared to deal with the manifestations of stigma. This could include psychosocial support for people living with a specific health condition or legal aid to cope with discrimination. It could also include training for healthcare providers or police to overcome stereotypes and discriminatory attitudes, or the development of new laws or policies to protect against discrimination. Next.
If you could, a little bit
everyone
slower.
Can mute. Okay. Oh, sorry.
Yeah, a little bit slower if you could. Thank you.
Sure. Okay. So as we don't have time to go into more detail today, for those who would like to learn more, I recommend 3 key guidance documents. The 2020 evidence guidance, which you see here next, and the 2 tools you see here that were launched last September by the Global Partnership for Action to Eliminate All Forms of HIV-related Stigma and Discrimination. And the links to these documents are included in the slides. Next. So now let's review some of the evidence-based or evidence-informed strategies available for eliminating KP stigma and discrimination and achieving the 10-10-10 targets. As I mentioned earlier, it's important to include interventions to address both the drivers and facilitators of KP stigma and the manifestations of KP stigma and discrimination. In the next few slides, we will review examples of evidence-based or informed approaches to achieve each of the 10s, organized by whether they address the drivers or the manifestations of KP stigma. And links to relevant resources are included in the slides. Next. So for the first 10, approaches to address the drivers and facilitators of KP stigma could include KP-led training for health facility staff on KP competent care and stigma-free provision, KP-led training of police on gender sensitivity, HIV, and harm reduction, direct service delivery models that minimize stigma and discrimination, such as KP-led drop-in centers, training peers to provide psychological first aid to those in crisis, and implementing U=U campaigns. Approaches to address the manifestations of KP stigma and discrimination could include psychosocial support for KPs who experience stigma and discrimination, strengthening referral networks, routine implementation of community-led monitoring and the PLHIV Stigma Index 2.0, pivoting to a more universal offer of PrEP in high stigma or criminalization areas, moving away from invasive risk screeners to a conversational approach that does not have to identify someone as a key population, and training case managers or other health providers to identify and refer those with mental health issues. Next. For the second 10, approaches to address the drivers and facilitators of KP stigma to reduce gender-based violence and inequalities include implementing evidence-based solutions to reduce violence and shift harmful norms, understanding the burden, causes, effects, and circumstances around violence through high-quality data, KP-led advocacy for policies and procedures that prioritize safeguarding KPs against violence, and work with law enforcement to reduce violence against KPs and program implementers. Approaches to address the manifestations of stigma to reduce gender-based violence and inequalities include training providers, police, and other staff on violence-specific adaptations to psychological first aid and integrating these adaptations into PrEP and index testing, ensuring timely availability and access to support services, including post-exposure prophylaxis or PEP within 72 hours of exposure, and psychosocial support, and ensuring and widely disseminating safe reporting structures, such as national crisis response systems and national reporting mechanisms for human rights violations. Next. For the third 10, approaches to address the drivers and facilitators of KP stigma to reduce or remove punitive laws and policies include community-led evidence-based advocacy with national stakeholders, utilizing CLM and Stigma Index 2.0 data, routine implementation of the Stigma Index, the national commitments and policy instrument, and legal environment assessments, developing a national strategy and operational plan for eliminating stigma and discrimination, implementing Know Your Rights campaigns, and routinely informing and sensitizing duty bearers on the legal, health, and human rights aspects of HIV, on relevant national laws, and on the implications for enforcement, investigations, and court proceedings. Approaches to address the manifestations of punitive laws and policies for KP include providing legal information and referrals, providing legal advice and representation, integrating paralegals into health facilities to provide on-site guidance and support for key populations and people living with HIV, strategic litigation, alternative or community forms of dispute resolution, and policy reform to shift the health and human rights environment for KPs. Next. So in closing, I would just like to share a few considerations for ensuring the safety and security of key populations. KP-led organizations, especially in hostile environments, experience chronic violence and other human rights violations, which negatively affects all aspects of the HIV program cycle. Ensuring data security by all organizations collecting and managing KP data is critical. Based on the context and situation, consider whether service delivery adaptations are needed. This could include expanding virtual or telehealth services, extended dispensing intervals and expanded multi-month dispensing where feasible, home delivery services, increased use of HIV self-testing, and increased provision of mental health and psychosocial support to affected program participants and staff. Adaptations may also include the temporary suspension of some interventions or activities, such as group outreach or moonlight testing. And lastly, I would just encourage you to utilize available rapid response mechanisms when needed. So next, and thank you very much for your attention, and I'm happy to answer any questions in the chat.
Thank you so much, Anne, for that amazing overview of the topic of stigma against key populations. As I said, we will share the slides, which were very detailed and have a lot of information and some great links so that people can review some of this evidence later at their leisure. We're now going to go a bit further into the available guidance and the practices that have been implemented to try to address stigma against key populations. And I'm going to call first on Dorothy Agutu of the Global Partnership on Ending HIV-Related Stigma and Discrimination, who will give some of the background on the guidance available. Dorothy, please take it away. Thank you.
Thanks, Tim. So Anne did a fantastic job laying down the groundwork on the 10-10-10 targets. I'm not going to repeat that. So if we could move to 2 slides after this one. Yes, okay. Yeah, so a bit of background about the Global Partnership for Action to Eliminate All Forms of HIV-Related Stigma and Discrimination, which is a mouthful, so I'll keep on saying just Global Partnership. And just to emphasize that this is a community-led and a community-driven initiative that is co-convened by UNAIDS, UN Women, UNDP, GNP+, the Global Fund, and the PCB NGO delegation. And it was on a strong call from the PCB NGO delegation wanting to translate the commitment on the 10-10-10 targets into action. And through that, there's a technical working group that facilitates this work and a community of practice that is implementing work at both national and at regional levels. It's very clear that stigma and discrimination not only exists in healthcare settings, but it also exists in education settings, in workplace settings, and in justice settings. And therefore, the Global Partnership has a mandate to address stigma and discrimination across 6 settings. This is healthcare, workplace, education, humanitarian, and justice and community levels. And we have different technical partners that the Global Partnership team and the technical partners are working together with in addressing the stigma and discrimination in those settings. And it's just to say that this work basically builds upon existing work that's already there, such as the Global Commission on HIV and the Law, the Global Fund Breaking Down Barriers initiative, and also capitalizes on the existing investments that are there. So increasing the capacity and capitalizing on that, such as Global Fund and PEPFAR initiatives. And the work that we do is purely, it's community-led, that's building on and leveraging on catalytic technical support, providing advocacy and legal policy change to ensure that that they are targeted and coordinated advocacy for policy and legal change that informs the community-based response. Next slide, please. Yeah, so as of January of this year or up to date, we have 30 countries that have already committed to the global partnership in addressing HIV-related stigma in the 6 settings that I just mentioned. Next slide. And so what do countries actually commit to? The countries commit to partnering with with civil society organizations, community of people left behind, key populations, LGBTI organizations, communities of sex workers, people using drugs, and transgender groups, people living with HIV, and other donors to identify policy and programmatic gaps, and then design and implement evidence-informed intervention, and then track the progress over a period of time. It gives the countries a chance to assess their current state of stigma and discrimination. This is where your stigma index actually comes in, and then the action that you are able to implement over a period of 5 years over the different settings that you have identified as a high stigma and discrimination prevalence, allocation of resources. It gives countries to really vigorously participate in a process of domestic financing and resource mobilization, but then also attracting external partners. And then the monitoring and reporting, which is quite important, where we use that to as our recommendations for indicators for future interventions and country examples as well. What's in it for the countries to join the global partnership? You get the technical guidance and support that is offered by UNAIDS and GNP+, as well as the other technical partners, WHO, UNDP, and the other co-conveners. We are able to work with you to roll out the guidance documents and the tools and build the capacity of the partners at country level, advocating and mobilizing for donors and prioritizing funding for community-led responses. We all know that we are constantly struggling with the shrinking civil society space, and funding for particularly key populations for this conversation is constantly being, it's reducing, so that's an opportunity. And then, the good practice that I mentioned, we have our community of practice, which we call the Global Partnership Ninjas, who share across the good models and interventions that they're working on, the visibility and political leverage, for other countries as well, and an international platform, and the resource mobilization that I mentioned. Next slide. Please tell me if I'm going too fast. What are our ways of working? At the very top, again, communities at the forefront of the response, civil society organizations, the active engagement of national networks, organizations in the program, the capacity building, the program design and implementation. It's led by communities. And then the technical support that I mentioned, and here's where the technical partners and the co-conveners come in, providing hands-on technical support in coordinating the national work, and then also the guidance tools that I mentioned, the M&E guide and the advocates guide, and some of which Anne had mentioned. This is a platform where we translate the evidence into action. Again, the data from your stigma index is very useful for the implementation and identifying where stigma and discrimination is prevalent. So we get to translate that at country level. One of the other greatest strengths of the global partnership is our strategic collaborations, working with other national, regional, global level institutions, Global Fund for Women, CDC, PEPFAR, the European Union. We have a myriad of collaborations and partners that we are working with, approaching different angles of stigma and discrimination. The community of practice that I again mentioned, our ninjas under the leadership of GMP+, really striving to document the good practices, some very key, wonderful examples coming there from humanitarian and workplace settings in countries such as Uganda. In Zimbabwe, you're looking at internalized stigma. So there's that. And then our gender approach, which is, we take, all the core leads. All our work is very gender informative, gender focused in how we apply the interventions at country level and the technical support that is given. Next slide.
Oh, dear, I'm so sorry we're running short of time, but if you can move along. Thank you.
I'm gonna do that in 2 minutes, hopefully. So a lot of this Anne already spoke to, so I'm not gonna say anything there. She did highlight some of those. So next slide, please. So those are some of the guidance and the tools. Just to mention that this, the new guidance is a companion for the 2019 and the 2020 guidance. Again, all these documentations and the links are provided there. And it's, it's for implementers and governments. Next slide. Yes, that's a disclaimer that the practical guide and the M&E guide, they are building onto each other. So you'll find the guidance that is in this document actually needs to be used complementary and cannot be used individually. Next slide. I know we don't have time. And yeah, so I just want to mention that for the new guide, that it's aligned and harmonized with the other, with the other guides that are there, the activist guide, the M&E guide. And, they are very specific in terms of it is intended for understanding how HIV, how does it do harm? Where does the process operate from? It's basically what Anne really took us through. And it has interventions for each and every of the 6 settings that are prioritized for the global partnership. I just want to check if do we want to move next and see if I've left out something? But I know, yes. And so the practical guide, this is the one that really talks about each of the settings, and it's, it's there for usage. I want to hand over to Erica, because Erica is actually going to be more specific about the healthcare setting, and which is very useful for this conversation. But just to mention on this very last slide that these are some of the advocacy and campaigns, tools and platforms that we have available for the global partnership. And our contacts are also there, so you can reach out to me afterwards. Sorry, I had to breeze through this presentation. Over to you, Erica. Those are country examples that will be quite useful.
Thank you so much, Dottie and Anne, for prefacing and giving a really wonderful overlay. As Dottie had mentioned, I'll really be talking about stigma and discrimination in the healthcare setting, and we've been asked to present on the guidance and recommendations. Go ahead, next. So within WHO, we are part of the global partnership, and our mandate is really to focus on HIV stigma and discrimination in the healthcare setting. Some of you might know that the Global Health Sector Strategy, which was released a year and a half, 2 years ago, the new one, it's on HIV, viral hepatitis, and STI. So when I speak today, I am thinking about all 3 areas, but of course the primary being HIV. So just to let everyone know that, in our global health sector strategy, we do think about stigma and discrimination. It's there's coverage, there's milestones, which are really important for goal setting and moving forward. Next, please. And one of the key documents that I would point people to in terms of understanding and or getting more information is our consolidated guidelines on HIV, viral hepatitis, STI prevention, diagnosis, treatment, and care for key populations. I've highlighted here some overarching good practice and guidance statements that are in the document that address things such as human rights and laws, the importance of collaboration from all the way from community to policymakers, healthcare services, making sure that they're available, accessible, and acceptable to people from key populations. We also talk about healthcare workers receiving appropriate, recurrent, and deep training to provide the appropriate skills and understanding and empathy, and so that they in turn obviously can provide non-discriminatory care. And it also talks about services making sure that they're in safe spaces and increasing protection, and some other areas. Next. Also part of the guidelines is this, I really like this schematic here. It just builds a little bit on what Anne presented earlier, thinking about the syndemics that require for multi-level interventions for key populations. Because I think we all know that if we just approach it just through healthcare settings or just through law and policy, we won't be successful. So I think this really addresses and looks a little bit into the details of, what do we need to be thinking about, all the way down to the biological and social factors of key populations. And you'll see on the left some STI information about the risks that people living with HIV or at risk of getting HIV are. Next, please. So those were, sorry, those were just some highlights from the key population guidance. Again, I would recommend going and investigating further. These are more general guiding documents, but they're still very applicable to key populations. And I've just highlighted a few. WHO has more, but there's some on monkeypox. There's the Global Competency and Outcomes Framework on the right-hand side, is really focused on healthcare providers and their competencies to provide dignified and inclusive care under universal health coverage, and it does address stigma and discrimination. There is a specific HIV module of this particular document. There's other areas, our EMRO, Eastern Mediterranean region has some modules that they've put out, almost going back to the basics of HIV education, which we know is which needs to be improved and what can help reduce stigma and discrimination. And there's work around person-centered care and integration of mental health with HIV. These are all areas that, when we're thinking about stigma and discrimination among key populations, are really essential. So these are just some highlighted documents. We do have more. Next. One of the newer ones is the role of viral suppression improving individual health. So U equals U, which Anne referred to already. And, we're looking into and trying to leverage this and the stigma reduction power for viral suppression, and how we can use this and make sure it's out there and being used appropriately, and not causing issues on the other side. Next. And then coming forward, we're really excited to let you know that we are developing a technical brief on HIV stigma and discrimination, with a focus on key populations. We're trying to move a little bit away from labeling stigma and discrimination always, as it has a bit of a negative connotation sometimes. So we're talking about a working title of providing good quality healthcare by ensuring dignity, equity, inclusion, and reducing HIV-related stigma. And this really is hopefully going to be, of course, we'll have the background and the purpose and all of that good stuff. But if you look at section 3, 4, and 5, we're really trying to make this document concrete for people to use and implement, focused on the healthcare setting, thinking about principles and components of what stigma reduction or reducing discrimination would be, and we'll be highlighting a lot of really practical and great interventions that we've learned about, and synergizing across sectors. And this builds also on the global partnerships documents, and just expands in more detail regarding the health sector setting. So I think that's all for me, I believe. Next. Yes, thank you for your time, and look forward to hearing more discussions.
Wonderful. Thank you very much, Erica and Audrey, for those really great details of the resources available, the guidance, and how these can be used in different settings. We see stigma and discrimination in multiple sectors and settings. So it's fantastic. We have all these resources, and I do encourage people to review the slides and then contact some of these presenters and the global partnership for further details, so that we can work collectively. We are running over time. I think we will skip the Mentimeter session, unfortunately, but we want to go now to a deep dive into 3 country examples of implementation of programs for ending stigma against key populations and people living with HIV. We have examples from Iran, from Tanzania, and from Thailand. And we're going to have breakout rooms for this. You can choose which breakout room you want. If you need the interpretation service, then stay here in this main room. If you can follow the English presentations and discussions, you can choose the Tanzania example in breakout room 1 or the Thai example in breakout room 2. So we're going to open up the breakout rooms now for individual country presentations, followed by some questions and answers. Please proceed to the breakout rooms. You'll see an option to do that where you can join a breakout room in the menu bar below at the bottom of the screen. So select the breakout room. Stay here if you need interpretation, but you can choose the other 2 English presentations.
Okay, Dr. Tyre, I think we're ready to go with people assigned to rooms. So it's wonderful you've been able to join us to talk about your experience in Iran. So over to you, please.
Thank you so much. Thank you. Hello, everybody. I try to have a very brief report about our activities in 3 slides. Iran joined Global Prevention Coalition in 2017 and Global Partnership on Ending HIV-related Stigma and Discrimination in 2018. Iran chose 3 fields of healthcare setting, community setting, and humanitarian setting as priority for intervention. Mindful of time, I just mentioned a few interventions as follows. About the healthcare setting, first of all, this is very important for us, developing anti-discrimination bylaw. The first ever anti-discrimination bylaw was issued by the Ministry of Health for private and public care healthcare setting. Development and in-service training package on HIV-related stigma and discrimination for medical practitioners in collaboration with Iran Medical Council. A group of representatives of medical practitioners were trained to further synthesize decision makers and also focal point experts on approaches to reduce stigma and discrimination in healthcare settings. The training will continue in form of continuous medical education forum. Provision of HIV prevention, treatment, and care services, and also harm reduction services to beneficiaries without discrimination and free of charge inside and outside the prisons. HIV clinics are linked with PHC system, which covers rural and urban areas of the country. More than 250 centers are in the country, inside and outside the prisons. ART is distributed based on DST approaches through these services, centers. The above services, including harm reduction services, are being provided equally in prisons. Continuation of receiving services after release is ensured by linking them to PHC. Since 2018, PMTCT program has been integrated in PHC to ensure full coverage of all pregnant women across the country. It's very important that all HIV and PMTCT related services cover registered and unregistered immigrants and refugees in my country. Implementation of an innovative anti-stigma and discrimination training model for a wide range of audience has led to provide uniform and coordinated education for all audience in several levels. Provider-initiated testing is being provided in comprehensive health centers, health houses, and midwifery units at different levels of the PHC, and also in harm reduction centers by trained personnel to increase access to VCT and reduce discrimination. Next one, please. Thank you. About community settings, a training package for CSOs was developed to reduce stigma and discrimination in communities with due consideration to age and gender specification. Manager of 30 CSOs from across the country were trained accordingly by this training package. The cascade training will continue for other members of HIV CSOs. 25 positive clubs that were established and supported jointly by the Ministry of Health and UNAIDS and financially supported by Global Fund until 2017 now has increased to 28 by welfare organization support, and these positive clubs provide care and support services to people affected by or living with HIV in a stigma-free environment. About the humanitarian setting, a response protocol for HIV-related stigma and discrimination in the context of humanitarian setting was developed and taught, and several relevant visual training for the target groups, including aid workers, were organized and they trained. During COVID-19, PLHIV and at-risk population were included as priority groups in the national guideline to receive PPE and vaccines. ARV, multi-month dispersion, and other innovative services such as virtual counseling and at-home services during COVID prevented people at risk or living with HIV from being negatively affected by impact of COVID-19 on health system. PPE were provided to the network of HIV CSOs, and the required ARVs were purchased in time to prevent any break in the supply chain of medicine and health commodity during COVID-19. 26 grants were allocated to HIV NGOs to facilitate community engagement and adaptation to COVID-19 pandemic in the context of HIV. Small grants targeted more than 14,000 beneficiaries with innovative action to protect communities affected by or living with HIV from impact of COVID-19. Next slide, I think the last slide, please. You can see the effect of our harm reduction program in reducing HIV among ID users in this slide. As you see in yellow box, HIV rate in ID users has reduced from more than 13% to less than 3% in recent 5 years. As you see in the diagram, IV drug using as the route of HIV transmission in new identified cases reduced from 78% in 2007 to almost 9% in 2023. All these activities and all this achievement and success is because of our harm reduction program, our strong harm reduction program. We have a long history in this field, and stigma-free or discrimination-free services, and also effective access to services in my country for harm reduction services and tools. For example, methadone is free of charge for PLHIV in my country. Needless to say, UNAIDS has always been a true support to our national AIDS program in mentioned intervention. Thank you so much, and I stop here. Thank you.
Thank you so much, Dr. Tayari. I had the pleasure of visiting Iran and the program way back in 2011 when the program was being rolled out in prisons, and I'm impressed to see that the progress that you're making. We have about 10 minutes for questions, answers, comments, feedback. If people can use their hands or indicate in the chat if they would like to speak. Again, any questions for Dr. Tayari first, perhaps? Okay. I'm not seeing any hands right now. Sorry. Yeah, I can't see all participants at once. Oh, sorry. Nua Cisse, please go ahead.
No, thank you very much for this excellent presentation. My name is Noah. I work with UNAIDS in Malawi. I think, what I would want to get your perspective on is on the needle exchange program, whether there is any evidence or any experience, on that. I'm saying this in the context of one, the need to prevention of our key and vulnerable population, but vis-a-vis some of the laws that are sometimes very discriminatory and be difficult to operate within. Like, for instance, the use of drugs is banned. So in your context, did you have any experience in that? And maybe to elaborate a little bit, in terms of any work that you did, in the prison setting. And what lessons, especially, you targeted the inmates, or the focus has only been on the officers? Over.
Thank you
so
very
much for your
Dr. Tayari, maybe just wait a moment and let's see if there's a couple other questions.
Yes.
I don't see other hands right now, but I'm just conscious of the time. Is there anyone else who would like to add to Nua's questions about needle exchange, the tensions between the legal environment and service delivery? Any other comments or questions right now? Okay, sorry to have interrupted you, Dr. Tayari. Please go ahead.
Thank you. Thank you so much. Thank you for your question. Indeed, we have a long history in working for IV drug users in harm reduction and having harm reduction settings. In 2008, we got a best practice score by WHO for our harm reduction services, and because of support of government at that time and after that, we have able to provide needle and syringe via several harm reduction services, and also methadone with low cost for everybody and free of charge for PLHIV. Providing needle and syringe is very important, and sometimes we could able to provide it in the prisons based on the politics, and sometimes not. But because methadone are available always in the prisons, can reduce the need to using syringe and needle. So recently, because of reducing rate of injection, most of the activities inside the prisons was about providing methadone. And recently, we do not provide needle and syringe inside the prison. But sometimes, based on the situation, if needed, we provided it. We had a great success in changing the ID users as patient instead of criminal situation. You know, we have a law that allow us that consider IV drug users a patient, and drug using is not just itself, it's a criminal. But by considering the patient instead of criminality, we can provide all services to IV drug users. I hope we have now we have more than 8,000 harm reduction centers throughout the country that provide HIV testing services, they provide counseling, provide methadone, and little by little we add some more items, for example, TB screening, and recently we add hepatitis C treatment to our harm reduction centers inside the prisons and in our VCT centers. I hope I can explain about this question.
Thanks, Dr. Tayari. We only have about 1 or 2 minutes left. Can I ask you just to elaborate a little bit on the legal situation of drug use? You just spoke about treating drug users as patients, not as criminals.
Yes.
My understanding, though, is that drug use is still illegal. Is that correct? And can you explain a little bit whether there was a law reform or just a policy reform?
We have a law that drug using should be considered as a disease, not exactly an illegal. For example, having a huge amount of drugs is criminal, but just the person, a drug user, is not a sinner, you know what I mean? And we can provide services to him or her in several settings. For example, in harm reduction settings, in VCT centers, inside the prisons, and drug usings. The IV drug users are people who need to support, not exactly criminalize them. I hope I can explain enough about this.
No, Dr. Tayari, that's very clear, and hopefully we can all learn more from your experience and how that legal shift towards decriminalization for users took place. But maybe that's in the next webinar. I'm afraid we're more or less out of time. Does anyone have a last very quick question for Dr. Tayari or reaction? Okay, I don't see any hands. Dr. Tayari, thank you again. I think
Thank you.
Again, your data shows how effective this approach has been. So congratulations to you and your team.
Thank you. Thank you so much.
Happy to facilitate that session with Dr. Kagashi. So without further ado, Dr. Agashi, I'm leaving the floor to you to please go ahead and present the experience of Tanzania. Please go ahead.
Can you hear me? Thank you, Simon. Good afternoon, good morning. This is Dr. Margaret Kagashi working with the Tanzanian Commission for AIDS, first actually leading the HIV prevention portfolio. So I'll be taking you through just for less than 7 minutes to 8 on what we're really doing in Tanzania in terms of addressing the stigma and discrimination on the KP programming. Next slide. So just to highlight key points on this, just to take for the team to take notes. Despite of everything, but Tanzania is cognizant of the importance of the KP in controlling the HIV epidemic, which is the good point from the country level. If the policymakers, the decisions makers knows that KP controlling the HIV epidemic, it is very crucial. And as a country decided to approach the situation in public health approach, covering everyone who needs service, they must be given that services. And that is actually looked at in terms of client-centered and vulnerability-tailored interventions. When we say vulnerability, we look at who is more vulnerable, where are the more risks, the incidents. So the evidence-based interventions are targeting which typology at what time, in which geographical positions. So also the services are being provided voluntarily, respected and friendly. I will see on the next slide. Non-judgmental, no discriminatory care, target hotspots, area with high-risk individuals. We know we can't find, the KP cannot just come in the facility because they're not sick. It's just they need services in their respective area. So also ensure safety of client. Also the KP services, let's take note on the KP services integration into the general health system. So it's there. But even though we offer the verticalized part of the services, basically we look on the specific needs of the client, and we say this is client-centered. Their KP needs more for mental health, their KP need more legal issues, all that. So it is integrated in the health system, so they are recognized in the general health system, but they are vertical, which targeted specifically for this population. Next slide. On this slide, I just wanted to highlight, we provide the differentiated HIV services for the KP, and we are targeting what service to bring, who should provide those services, where we should provide those services, and when. This is stipulated clearly in our DSD guidelines, which are targeting the KP interventions in country. So what I know, we provide services according to the HIV SRH issues. We provide HIV testing, prevention. We have biomedical, behavioral, and structure. We have care and treatment, but we also have other services like legal, rehabilitation, and mental health issues, depending on the KP needs. So who providing those trained healthcare providers? We may not be reached the 100% of being trained on KVP-friendly services, but we train that we recognize this is KP-friendly services facility. Also, we have the lay cadres who provide services, are the most critical people reaching the KP population in Tanzania. So KP peer educators, community health workers, volunteer expert client are the one we are using to make sure this the population is being reached. But we also have other cadres, as I said, we provide other services like legal and mental health. So where we provide, we have health facility-based, but we have community services delivered, like hotspot area, mobile clinics, tents. These are the areas where they can get services. When we provide those, depends on the needs of the client, as I said, this is client-centered. So during normal working hours, we provide extended hours needs, but we provide weekdays, also weekends, at night, during the night, during the day. So depending the preferences of these clients. So we have this moonlight testing and all that. So this is just a summary of how this has helped us to make sure the services have been reaching the community we are targeting. And my last slide, next slide. We just need to take a couple of minutes to look at what is really happening. I've already said what are we considering as the health approaches, what are the key issues in that health approaches, what are we looking at? But I categorized the experience of addressing stigma in 3 categories. 1, the enabling environment, but we needed to have community engagement and empowerment. So we had also to have oversight and coordinations. These are the area just categorized to make sure it may not fall like when we're done with this, we go, but these are the things we do practically we are doing at this point in addressing stigma and making sure we reach the targeted populations as required. The first thing is we have existing policies and guidelines, actually, which stipulates how services to be provided. We had HIV policy, which states the provision of service to everyone, doesn't discriminate anyone. Everyone needs to actually to be reached with services. Also, we have stigma strategy, which has been reviewed last year, 2023, which has a component. It's a general KP stigma strategy, but it has a component of KP within it, which actually says they need that services too. So we have national KVP guidelines, which are using to provide services, where to provide, who to provide, what are the minimum package for a KP, all that have been in the KVP guideline. Also, we have training KVP training package, and SOPs are the standard operating procedure, which guides the facility, the communities, the providers. How do we provide services, to who do we provide the service, with all the guidelines. But as I said, we have the DSD guidelines, as I provided highlight on the last slide, showing how the DSD is being operated in Tanzania in terms of KP. Also, we have the health strategic plans, which actually explain the general HIV, including the key populations. When we talk about HIV, it's the KP team is actually it is a priority population in that area. So in enabling environment, another issue we are looking at is human resource for health, because you cannot provide these services if you have not trained the human, so you don't have human resource. So we have categories of human resource. You have healthcare providers who are already trained on KVP friendly services, and stigma and discrimination using the total facility approach. For those who know, this approach was introduced in 2018. So this is we are using this training to make sure the total facility approach has been an indicator to use to train the healthcare providers on stigma and discrimination. Also, we have KVP, peer capacitated on demand creation, interpersonal communication, linkage, and referral. As I said on the DSD party, the peer or the communities themselves, they need to actually, they're the ones who are the key players on service delivery to the key pop. So we are capacitating them. We have a training package targeting the peer and community providers. Also, we provide services in terms of his facility and offering also the outreach services. Also, we have health management information system ready. These are the enabling environment, because you can provide services. If you don't record anything, how can you say I have reached how many? So we have the system already. This is health, also non-health at the same time, just lacking the word non-health. So we have KVP, many framework indicators are there. DHIS is recognized the KVP. Also, we have a unified community now system, which takes the client level data from condom use, and other services have been provided. Also, we have the TOMSHA, which is the typical community, including stigma and discrimination being picked up in this M&E system. So this is the enabling environment I'm referring to at this point. So when we go to the community engagement and empowerment, Tanzania has a KVP forum. This is typically the KP constituents. They oversee over 120 the civil society organization and the community-based organizations. So they are overseeing, actually, they are KPs themselves, they're overseeing the KP-led organization. If you need to work with the KP-led organization, you need to reach this the KVP forum, which is legally there and approved by the Minister of Health and Tanzanian Commission for AIDS. And they have 2 seats in that forums, which we recognize they're there. So we are working with them in everything we plan, we design, we do with the KVP forum. Also, recently, we were able to develop the Community Violence Prevention and Response Committee, which addresses all the violence targeting the KP. These have been developed from the regional level to the district level, to the village level. So we have these communities now, Community Violence Prevention and Response Committee. These are developed just to address the violence part of every KP which actually been faced with any issue of legal and other being criminalized or put into jail without any reasons or because they're KP. That is where this Community Violence Prevention and Response Committee comes in. So this has been approved by the National Multisectoral KVP Subcommittee, which include the KVP representative within the. Also, we have
Dr. Kagashi, I'm just cognizant of the time, and I wanted really to open because this is really amazing work. So I don't know if you have more to go, or we could just open for questions and answers.
This is the last slide I have. That's the only one.
Okay, great.
But probably my last word should be that we have also the oversight and coordination mechanism. This is very critical. This one chaired by the Prime Minister's office, but is co-chaired by the Ministry of Home Affairs, the police commissioners. They are part and parcel of that, the National Multisectoral Committee. Even though we have the different typology of the KP, which have the seats in this, the National Multisectoral KVP Subcommittee. So these are the main key issues on addressing and making sure that the services are reaching the targeted population.
Thank you so much. I think this has been an amazing and very comprehensive response to the stigma and discrimination. You've really cited everything that is supposed to be in a very solid program. And I wanted to make sure that we also give room for the participants here to say what they think, what is really happening. Are there any questions and answers? I would like to open the floor. I see Jabwil, do you want to come in and speak to this thing you were mentioning in the chat?
Oh, good afternoon, colleagues. I'm Jabu from South Africa, from the National AIDS Council, also overseeing the key populations program in the country. And I'm interested to learn more about this KVP forum that has been established by Tanzania, and to understand why it would sit under the Home Affairs sort of ministry instead of health. I think I'm just interested to learn more about that. Thank you.
Thank you, Jabuli. Do you have another question before maybe Dr. Margaret, you want to take that one until other people come on board?
Okay. So there's difference between the KVP forum and the National Multisectoral KVP Subcommittee. These are the different bodies. The KVP forum is typically only the KP people leading that in country. But the National Multisectoral is a subcommittee which include different ministries. So because we know actually the HIV is not health issues, it contains multisectoral approach, so it cannot sit in the health sector. It sits in the multisectoral ministries, which is actually the NAC, the Commissioner for AIDS, which actually coordinates every HIV interventions in different organizations in different areas. So that is where. So the KVP forum is typically for KP only. They're the one who leading that. We're just members, just 2 members of the government have a seat on that. But otherwise, they're the ones who runs the forum.
Excellent. Thank you so much, Margaret. I think we have also another question from the floor on CLM. How have you, to what extent it's been leveraged? He says the presentation is silent on CLM. I know you mentioned employing CLM, but maybe more on that. And then there is a question on how is this PPR resourced? How funding goes into that?
Maybe I can assist to answer on the chair. Yeah, Marin is the chair of Tanzania. Yeah, sure. I'm the representative of Tanzania Canberra Population Chairperson. Actually, this year for COP23 year 1, PEF had approved 300,000 for KP specific CLM, where this will be coordinated by the KVP forum. So we started by preparing tools for KP specific, and this process was approved by the government. So KP-led CLM is being conducted, and now we are in the process of starting data collection. Thank you.
Thank you, Marinus. That's really excellent. So back to the question on how is the VPR resource? And I see another question. Yeah, go ahead.
The VP resource for VP, yeah. So we actually PEF also approved about 300,000 for VPR, and we started engaged with the government on first to approve the VPR, I mean violence prevention response, which is the crisis response mechanism. So it was approved, and now we have started reviewing tools that will be also incorporated in the DHSS tool. So this VPR actually together hand in hand with CRM also monitors human rights violation, monitors implementation at health facilities, as well as VPR. So they're just kind of two activities that are going together, and through VPR, I think we can come out with issues that could be addressed and done advocacy at national level, particularly on the policy issues. Thank you.
Thank you so much. I mean, we are running into closely to time, but there are two questions on what the key Ps are when you mention key Ps, and also if you can provide some success stories on the violence part. Maybe if we don't manage to answer that, we could always, you know, like ask you, Margaret, and the team to be providing that later on. But these are the ones that we've seen. I don't know if you can come quickly on that. You have 3 minutes, 3 seconds or something. Do you want to come back quickly on that?
Productive health and right service, as well as other healthcare service they may need. It is crucial that everyone has equal access to these services, regardless of their sexual orientation or gender identity. We must work to eliminate any barriers that may prevent individuals from accessing the service that they need. Our mission to lead on enabling sexual health and rights of LGBTQ+ people and diverse sexual orientation and gender identities. It's important to provide comprehensive people-centered and friendly service on sexual health, social protection, and human rights advocacy. By doing so, we can advance equality and equality in society and to ensure that everyone has access to the care and support they need. So in our approach, we utilize and key population-led health service model. It's called KPLHS, which I will explain to the next slide, at M+ Foundation. And we empathy a human rights framework to promote stigma and discrimination-free service. Target populations, men of sex, men, transgender people, young key population, people living with HIV, sex workers, people who injecting and using drug, and also people who are still in the prisoner. And we are so grateful for our collaboration from PEPFAR, USAID, EPIC, IHRI, Institute of HIV Research and Innovation, Bangkok, Global Fund, Department of Disease Control, National Health Security Office, and also Thai Health Promotion Foundation. Next slide, please. M+ Foundation provides service to help reduce stigma and discrimination because stigma individuals face internal and external stigma, including self-stigma and public social, professional, and institutional stigma. Service providers, there is a lack of understanding to gender sensitivity and sexual orientation, leading to stigmatizing attitude and discrimination. The third one, service availability and accessibility. There is a lack of need-based and client-centered service, as well as the need for space and create a friendly, non-judgmental atmosphere. Issues such as limited service hours, days of operation, and transportation option also contribute to difficulties in access to services. The fourth one, health service system. Non-Thai clients, particularly undocumented migrant workers, lack access to health insurance scheme within the current system. And the last one, legal challenges. Unfavorable laws regarding sex work, drug use, and migrant workers, harder access to service tailored to the need of these vulnerable groups. How M+ Foundation provides service to help reduce stigma and discrimination by implementing the key population that helps service KPLHS model under reach, recruit, test, treat, prevent, and retrain. Here is how they do it. The first one, KPIS model, create a safe space through health provider and counselor from the key population who have a deep understanding and empathy of sensitive topic. Second, reaching and recruiting clients through activities tailored to group interest and need, such as sports, contests, and online platforms. And the third one, minimizing loss of case by retaining individual in service. For key feature of their approach include providing people-centered friendly service and non-judgmental, and to implementing a non-discriminatory policy, integrating one-stop service within the same day. We offering HIV and STIs hormone testing, same-day prescription for PrEP, PEP, and ART medication for both treatment and prevention. For our stigma and discrimination campaign and public advocacy, M+ has been doing since mid last year. For example, U equal U literacy and say zero. Stop Stick for All campaigns, anti-bullying toward LGBTQ+ students and community members. What action do we need? No one left behind, more inclusive. Get to know and understand what is U equal U. Next slide, please. Among community health workers, for internal training staff, annual stigma and discrimination training. We do e-learning from Department of Disease Control and UNAIDS to address gender intersectionality. Gender and intersectionality is a term of use to explain an idea that various forms of discrimination, such as those centered on race, gender, class, disability, sexually, and other forms of identity that do not work independently, but interact to produce particularized form of social oppression. Internal training at M+ for everyone, including the cleaner as well. How do you address intersectionally in the workplace, like said before, or nationality, religious, job position, political affirmation, or even mental status. So that way, we can create a more inclusive environment for everyone to recognize intersectionality and different stages of the employee life cycle. Continuously review your policy, process, programs, and initiatives. The third one, actively seek different perspective and feedback. Fourth one, to build a functional DEI dashboard. And the most important one is self-help for both of us to do some sort of live self-education and up to date. And after that, we share the information and discuss about this again. Talking about
interrupt Kunray, there's 1 minute left of the presentation.
Okay, talking about external training, we create structural stigma and also the HR management with the code of conduct of staff. For S&D free service, code of practice for staff, we create SOP for all HIV service. Once a year, we got a review and renew and up to date about S&D by M+ staff and under FHI 360 usage and PEPFAR. Once every year, we do assessments for both the service quality in community and service quality in facility. The most important one about the challenges for stigma and discrimination policy code of practice, it's only for key population people who live with HIV, key population target, but other example like Hunan, KPL, HIV, migrants, undocumented, and people, even people in the community still lack of knowledge, and talk about what is S&D, HIV/AIDS literacy, and they still believe most of LGBTQ relate to HIV/AIDS, including drugs and sexual. Fifth, people who have left behind because migrants without document using substance, work in sexual entertainment, intersection identity, address vulnerable and behavioral rather than group, strengthening system of health, and plus also working on the goal and philosophy of theory start from ourselves first. That means every single staff have to know and balance between quantity and quality, practicing on self-awareness, mindfulness, spiritual improvement, moral behavior, attitude, belief, and respect. Nevertheless, the most powerful impact and still happening, that's a big challenge for us. From nowadays, I believe is the social media is a big impact to the society. Example like social media news, billboard, misinformation about HIV/AIDS, and they're still doing in the same way, with the same words, characterize, bully, panic, or making fun of us. What we are doing now, and plus now create more activities, campaign, media production, skill contests, bring more self-esteem, or inside out for key population and for all, especially to young people, to create more challenge and capacity, more workshops, speak up about themselves, sex education, what is harm reduction, strengthening automatic negative attitude change. And we will keep doing, we will never give up to create more acceptance and equality, inclusive education, non-discrimination policy, human rights campaign, equal right for LGBTQ individuals, public awareness and reducing gender stigma, promoting awareness and problem management, protecting rights and problems resolution, developing non-stigmatizing model, equal literacy and project. This is all representation from MPlus Chiang Mai today. If you have any further questions, feel free to ask. Thank you very much.
Thank you so much, Kunray, for such an exceptional presentation and overview of the work that, and the really important work that MPlus is doing in Thailand. We haven't had any questions in the chat, so I'm now opening up the floor. We'll have time for 1 or 2 very quick questions. So if somebody has a question, please raise your hand. In the meantime, I have a question for you. And
yes,
so,
for sure.
As part of what MPlus is doing, the services that you're providing to reduce stigma and discrimination, you mentioned campaigns and public advocacy and the Stop Stig campaign. I wondered if you could tell us a little bit more about that campaign.
Yes, talking about a Stop Stig campaign, we got support from the Thai government. It's called Thai Health Promotion Foundation. We target the audience to the young kid population, and also including the general population, people living with HIV in young age. The 4 main points of this Stop Stig campaign is to public awareness and reducing gender stigma. We educate about on HIV prevention, human rights, sexual diversity, to reduce stigma in relationship. And also we promoting awareness and problem management, support awareness and problem for those who infect and affected. The third one is protecting rights and problem resolution by developing mechanisms to protect right and resolve issue and make sure the effectiveness at the community level. The last one is developing non-stigmatizing model. We create non-stigmatizing models and practice generate data for scalable implementation in different regions. And we not just do in the community in the city, we also across to the rural area, to the school that's kind of like never reach out to us. And we keep doing this every 3 months to the same school.
Oh, that's wonderful. So we only have about 30 seconds left. So we may get cut off. I want everybody to join me in a thunderous virtual round of applause for Kun Ray. And while we're doing that, perhaps you can say, if you had one piece of advice for other organizations about addressing stigma and discrimination, in 10 seconds, what would that one piece of advice be?
I would definitely say attitude, because like I said, I have to start for myself, and also the attitude. If you have a fundamental of mindfulness, self-awareness, and also the dignity of spiritual things will work well. And also it's also it's keep me stigmatized and discrimination free from that.
That's wonderful. And I think we're at time. So everyone, please thank me. Join me and don't thank me. Join me in thanking Kun Ray for such an amazing presentation. I expect that we're going to be called into the big room now.
Thank you so much, Khop Kap.
And I believe that your slides will be available to anybody who is interested, and that you're also really happy to take questions about the work that you're doing and that M+ is doing.
Right. And also for further information, the last slide, I have an email and contact. You can reach out to me, and I can, give the feedback and answer. Thank you.
Yes, thank you to all of the three presenters and groups. It was great to hear, just to dip into some of the practical examples at the country level, how this wealth of guidance has been implemented and the programs that have been developed by individuals and services and communities in different countries. I think we getting close to time, but we will now have a few takeaway messages from government, from community, and from development partners. We'll start with Cindy Matsi from the Ministry of Health in Eswatini. Please, Cindy, with two takeaway messages that you've taken from this session.
Good afternoon, good morning, everyone. For me, I think I really appreciated the laydown that was made by the first presenter, where highlighted the impact of stigma on the work that we have done, especially in the achieving of the 95-95, if we are not addressing the issue of stigma. So I really appreciated how the stigma and discrimination hinder the achievement of the 95-95. So it is important for all of us to address the stigma so that we can maintain the gains. Where we have gaps, we can work on reducing that. And also the societal enabler targets, the 10%. It was really laid down what can be done as countries. I've seen that there is need for us to train the KP themselves because there's stigma that exists within them. There's also the capacity building of our healthcare workers for the healthcare settings. They also need for the police to be sensitized on the issues of stigma, as that also hinder the access to our services that we are providing as the health system. The differentiated service delivery is also important, which I've also picked from the presentation, which is going to help us to address some of the issues that we are seeing. I also really appreciated the experience or what other countries are doing in the different type of stigma that we are faced with as countries. So I really appreciated the presentation. But what I can say, the time was not adequate. The presenters had to rush. So if that can be also addressed so that we can benefit from this presentation. Thank you so much.
Thank you very much. We have a Herculean task here to get through such a complex, diverse issue that really needs much more time. We'll move now to Anna Shapiro of the Global Network of Sex Work Projects for your reflections. Thank you, Anna.
Great, thank you so much. So on behalf of the Global Key Population Networks, I'd just like to thank everybody for their presentations today and just reiterate how much of a role stigma is playing in perpetuating inequality increasing our vulnerability to HIV and reducing our community's access to HIV programming. In terms of some key takeaways for me, in terms of the evidence-based guidance that we have to address stigma, firstly, I think one key takeaway is that we need to advocate for removing all structural barriers to stigma. For example, removing punitive laws against key populations and promoting anti-discrimination laws as well, and taking measures to address violence, which is very much intertwined with stigma as well as vulnerability to HIV. And the second key takeaway is that key populations need to be meaningfully engaged in the design, implementation, and evaluation of HIV programming. So that can be, what's been talked about, like key population-led sensitization training for healthcare workers, investing in peer-led service delivery models, developing key population-specific services that are tailored to the community's needs, and also finding ways to meaningfully involve key populations in addressing some of the negative impacts of stigma, both individually and at the community levels. So in sum, for us to reach these global targets that we've spoke of, we need to just continue to advocate for rights-based approaches that are really centering the needs and priorities of key populations, because we are the foremost experts when it comes to the stigma which is affecting our communities. And so we just can't effectively address that stigma without meaningfully participating. So that's, I think, the most important message there's to impart for me.
Thank you, Anna. Absolutely. The community-led response is the most effective, and ensuring people are involved and empowered to tackle this critical issue of stigma. And now, just finally, we'll have Matteo Casolato from the Global Fund for your perspective.
Thank you, Tim, and I hope you can hear me fine. Again, I just wanted to thank the SSLN, but also all the presenters for this time together. I think it was really great to reflect on stigma and discrimination interventions. Like Anna, I think my main key takeaway really it's about having people at the center, especially when it comes to design and implementation of stigma and discrimination interventions. We still see often implementation of interventions like in stigma and discrimination training activities for healthcare workers that do not involve key populations of people living with HIV, and that's a big missed opportunity. We need to correct that. My second message is most about the planning in a comprehensive way, trying to really avoid silo. We saw how stigma exists at various levels, from the individual internalized stigma to the community, to the household, to healthcare settings, to the workplace and justice sector and all that, right? So, really, when you plan your interventions, think, across all these different settings, and not just in terms of settings, but also, as again, Anna and others have mentioned before, think about the manifestations of stigma, but also about the root causes and what we need to be doing to address that, criminalization being a big one, for instance. And the last thing I would say, it's also a commitment to measure the impact of the intervention that we have, both in terms of scale, so are we, how are we managing to go nationwide with our stigma and discrimination interventions, but also, also the impact of the interventions, trying to see if they're really, if we are affecting change. So, exercises like stigma indexes are really relevant and important, together with other, demographical surveys and all that. But just this thing from my side, and thank you so much.
Thank you very much, Matteo. I'm sorry, there's a bit of noise outside here, but I want to thank all the presenters for a very rich session. I'm sorry we've had not enough time to cover everything. We've really just scratched the surface, I think. I would encourage everybody to work within the forums where you operate and work and communicate and really talk about this issue of stigma and discrimination by creating a space for discussion where you then can start to see how to identify it and see the challenges that it brings and look for the solutions. The partnerships are critical here, as been mentioned, between government, civil society, development partners, but other sectors as well, such as the private sector, academia. We have to work together on this and address these issues. And community empowerment remains central, giving people the space, trying to increase the space for civil society to operate is critical, as well as really sensitizing service providers in all different sectors, so that we do look for ways of including people. And I just end, I think, by returning to Erica's point of trying to make a positive view of this and not always just mentioning the negativities of stigma, looking at the healthcare setting, the dignity, equity and inclusion principles. And we have a very similar expression in a broader society and cultures of ensuring diversity, equity and inclusion. So this is a positive way of trying to ensure that everybody is included, respected, has a space to be themselves and not be stigmatized. This is our goal and what we all have to work towards. I want to thank all of the presenters, all of the participants and attendees, and we will be sharing the recording and the presentation. We've had also some links to people who you can reach out to think further about how you can address stigma against key populations in your specific settings. So thank you everybody again for participating in what I think was one of the most richest discussions we've had to date. Thank you so much. We'll draw it to a close now. Bye-bye.